Hello, good afternoon. Welcome to this session on public health. The science of public health, where's the evidence? I don't know about anybody else, I've already been to a couple of sessions this weekend which are relevant to this. I went to one yesterday about drinking and gambling, in which I somehow cast myself as a riotous drinker and gambler. I only wish that were true. So what we're doing this afternoon as part of the welcome sponsored by a medical strand is we're looking at public health as an applied science. Where is the science? Where's the evidence? How do we relate the evidence, the science, the research to policy? How do we relate things that are studied on a population scale to individuals? How do we relate actions that governments and other bodies might want to take to what we as individuals want to decide? I've got a terrific panel of speakers. So they're going to speak for about 5 to 7 minutes each, and then we might have a little conversation up here, and then it's over to you to join in. We've got an hour and a half. I'm Timandra Harkness, by the way. I'm a kind of, I don't know, I do a bit of this, and I do a bit of journalism. I do a little bit of radio. I do some comedy about science, as you do. I'm not particularly qualified to be here, except that I'm interested in this, and I managed to get hold of 4 really good speakers. So there you are, so you're stuck with me. So, I'm going to introduce the speakers briefly, and then I'll tell you a little more about them just before they speak. We have Dr. Michael Fitzpatrick. Then we have Henry Ashworth. See, I'm failing already, can't remember the order they're speaking in. Then we have Dr. Elizabeth Pisani here on my right, and finally Michael Blastland at the end. And because we've got 2 Michaels, I've asked, and Dr. Michael Fitzpatrick has very kindly agreed to let me call him Mike. Well, I don't know if that means any of you can. So we're going to start off. We'd have to ask him afterwards. We can't presume these things. So Mike is a GP, but he's also a writer. He's written a couple of books, including The Tyranny of Health, Doctors and the Regulation of Lifestyle. And he continues to write on medical and political subjects, which I think should cover us nicely. So, Mike.
Yes, thank you, Timandra. If you go down to Finsbury Park on a Saturday morning, which is my local park and I'm inclined to do, you will find, first thing you'll come across is the park run. That's about 200 people running 5 kilometres around the park. Just next to the park run, you'll find British Military Fitness. That's another 100 or so people who basically pay somebody a considerable amount of money to, they dress up in brightly coloured gear, and an old ex-British Army squaddy shouts at them like a sergeant major, for which they pay a considerable amount of money. If you go a bit further down, you'll find a load of people assembling in pink for a Cancer UK sponsored walk or a run. That varies from week to week. That's apart from there's an outdoor gym available, which is also fully occupied with people pumping iron in the park rather than in an inside gym. That's apart from American football, ordinary football, tennis. In other words, the public park in London has become dedicated to the cult of fitness to a most remarkable degree. Not good enough, I'm afraid, for the promoters of public health, because you will have noticed the major public health initiative of the last week in London was the declaration by the team of Lord Aradarzi and Boris Johnson got together for a major announcement that smoking is going to be banned, or to call for smoking to be banned in all London public parks, which is very considerable. It covers about 40% of the area of the capital. And a raft of other measures, the familiar measures against obesity, problem drinking, and all the other scourges which we're familiar with, the public health people trying to stamp out. The presentation of this initiative is very interesting because there was Lord Aradarzi on the one hand and Boris Johnson on the other. And Lord Darzi was very keen to emphasise that he was speaking as a clinician and a scientist. And what he was presenting was clinically led, evidence-based policies for people to pursue. Now, as it happens, Lord Darzi is not a scientist at all. He's a surgeon. Now, I don't want to cast aspersions on surgery, but science it's not. He's an expert in keyhole surgery, and I'm sure his opinion on keyhole surgery will be very useful for anybody to get hold of. But keyhole surgery expertise, I think anybody would instantly recognise, does not qualify you to pontificate about public health. What about the issue of his expertise in terms of providing science-based evidence? If you look at the report, which I'll save you the trouble, I've laboured through the 108 pages of the report, you will find there's no actual evidence presented in. There's no references that you'd recognise as scientific, the customary way of indicating scientific evidence. But there are two pieces of evidence that crop up in the report. One is the claim, which is endlessly repeated, appears in the press release as well, the claim by Michael Bloomberg, the former mayor of New York, that in New York City, a similar raft of measures achieved an increase in life expectancy over his term of office of 3 years. Fantastic. Get 3 years older if you follow all these policies. Well, I mean, I'm not an epidemiologist or a scientific expert, but I could tell you that the life expectancy of everybody in every city in the Western world has increased by 3 years over the term of office that Bloomberg has been in. But, you know, that would seem to be a very vulgar point to make in response to this, because everybody thinks, oh, well, that's really good. And Boris obviously wants to imitate the same thing in London. So that's the first piece of evidence on which this is supposed to be made. And this is repeated as good coin in all the propaganda that followed, all the press coverage. The second one is that there's been a 2.4% reduction in hospital admissions for heart attacks in the 12 months following the smoking ban introduced in England in 2007. 2.4% reduction. It sounds very scientific, that. If you can quote something to several decimal places, it sounds even more convincing. There's no reference for this, but I have, on your behalf, chased down the reference for this, which goes back to a paper published in the British Medical Journal in 2010, which was based on a study of the whole population of England over that period, and it shows, indeed, what is described by the authors as a small but significant reduction, 2.4% in hospital admissions for people with heart attacks over that period. What I think if you look carefully at this report, what it shows, it confirms the great epidemiological principle that if you torture the data fiercely enough, it'll confess to something. Because a 2.4% increase is it may be statistically significant, but any wider significance it just doesn't have. If you look at the famous Doll and Hill paper about the association between cigarette smoking and lung cancer, it showed a factor of 10 increase in the risk of lung cancer for people who have ever smoked. If you've ever smoked, your risk is 10 times increased. If you smoke still, at any degree, still smoking, it goes up by a factor of 20. If you're a heavy smoker of 20 to 40 a day, it goes up by a factor of 50. So we're talking about anything from 1,000% increase to 5,000% increases in risk. So the really strong association. The great point that Doll and Hill made about the criteria by which you can decide whether a statistical association can be called causative, the strength of the association is the very first one. There's a whole load of others. The reduction of 2.4% doesn't even meet the first of those criteria, never mind any of the other ones. God. So, I mean, the quality of even some opponents of this made the point in the paper that this is based on the strong studies about the association between passive smoking and lung cancer, and not just lung cancer, but also coronary heart disease. It is not. There is no strong scientific data of that sort. There are papers about passive smoking that show passive smoking increases the risk of breast cancer considerably. Well, nobody knew that active smoking caused the risk of breast cancer, never mind passive smoking. So a risk that could not be identified with active smoking is suddenly discovered with passive smoking. It just couldn't possibly be true. There is a great amount of publications on this question. So in other words, if you look for the evidence, it just isn't there. And so what you've got here is a clinician and a scientist who is actually a politician standing next to a politician. He's a scientist pretending to be a politician, standing next to a politician. I mean, at least Boris is an honest politician. He's not pretending he's really doing anything other than advancing his political career here. He's, in a sense, pretending to be a public health doctor. And it's actually, the whole thing is a bit of a sham because everybody knows Boris has no powers to introduce any of these measures anyway. The only place he can introduce them is in Trafalgar Square, which symbolically is where this whole thing was held. So that is if you say, where is the evidence? Major public health initiative, you look for the evidence, you will find it isn't there. Just quote one sentence that really leapt out at me of this report is, questioning the moral character of people who are obese is as useless as it is self-defeating. That's, to me, I read that with great amusement. It's like a Freudian slip, you know, it sort of blurts out from the report. I mean, who suggested that anybody was casting moral aspersions on people? Only the whole burden of this report. I mean, that's what it's all about, is people who smoke and drink and do all these unhealthy activities. They are basically ignorant and stupid and lazy. They don't know what's good for them. They've got to be told what's good for them, and they've got to be nudged in the direction of behaviour that's considered appropriate. It's patronising, it's degrading, it's bad for science, and it's bad for the public.
Mike Fitzpatrick. Only slightly ignoring the red card, because he knows he's safely far away and I can't actually slap him without you seeing.
Is that a warning to your next speaker?
You're so good at this psychology stuff, Henry. It's uncanny. It's almost as if you used to be a member of the Behavioural Insights team in the Cabinet Office, where you led the team's work applying behavioural science to public health policy. Which, by coincidence, happens to be true, but he's now the Chief Executive of the Portman Group, which is the UK alcohol industry's social responsibility organisation. Before that, his contributions to public health might have been slightly more questionable, because he apparently introduced the sport of kite surfing to the UK and Jamie Oliver's 15 restaurant to Cornwall. So, Henry Ashworth, give us your 5 to 7 minutes.
Just to explain my career path, probably would sort of take the time. So thank you very much. I just want to talk about 3 things briefly to sort of open up. One is really around context. I mean, I now work exclusively with the issues of alcohol in society, trying to reduce issues around alcohol misuse and harms associated. But I guess one of the things that we see time and time again is that there is a very, very different picture if you look at national versus local trends around alcohol misuse. So a statistic many people don't realise is that whilst trends are broadly moving in the right direction at a national level, you then find there are significant outriders at a local level. So for example, in Blackpool, you're 3 times more likely to suffer from alcohol-related liver disease than you are amongst the national average. But I guess the problem with this, or why this kind of context is important, is that there is an overriding public health belief or set of what are called best buys, going right back, if you like, to the World Health Organization, that put a number of non-communicable diseases in the same bracket. So they say that what is effective for tobacco control in terms of increasing price, reducing availability, and restricting marketing will apply equally to alcohol, will apply equally to obesity. And I think one of the things I want to put forward as a provocation is that when we start looking at the science of public health, we have to look at it through both a political lens. So I've talked about national politics, I've also talked about local politics. But also we have to look at it through, to a certain extent, a certain degree of common sense. So is it common sense to be applying the same set of principles to tobacco policy, alcohol policy, and obesity policy? And my starting provocation for this with alcohol would be to say that since 1979, we are incidentally now, according to the government statistics, we are now drinking at the same level that we were in 1979. Alcohol consumption reached a peak in 2004 and has dropped back now to the same level that it was in 1979. In that period of time, bearing in mind that it's about price, availability, and marketing, alcohol's become more than 50% more affordable since then. It's become more available since then, and it's 20% more likely that you will see alcohol marketing than you would have done since then. So the science isn't quite stacking up with the evidence, which brings me to my other major point on this, which is that where are the statistics coming from that are being used? If they're official government statistics, or are they coming from other sources of data?
Such as industry.
Well, such as industry or anyone else? We'll start later. So question, the evidence behind clinical trials is very, very different to the evidence behind a random control trial, which is very, very different from the evidence that comes from modelling, whether that's retrospective modelling or indeed predictive modelling. And the most dangerous element is when these different types of evidence start getting conflated in order to prove a hypothesis which has already been made and accepted. So the third element that I wanted to touch on was around the conflation of roles. There is a conflation, I would argue, between people carrying out research into public health and those who then move their research positioning into a campaigning mode, where the campaigning is then trying to prove a hypothesis which has already been made. And as you've already alluded to, I work with the drinks industry. There is a pretty obvious conflict of interest that the drinks industry has. It's put on the table. The drinks industry is there to make a profit, to optimize its profits by selling alcoholic drinks. That's why it's a drinks industry. But there is also a conflict of interest through other industry sectors. So, for example, you will have seen only last week a report around 10 million hospital admissions due to alcohol-related disease. The government's official figure for alcohol-related hospital admissions is 325,000, against a figure put out last week of 10 million. 6.5 million of that 10 million was based on an Ipsos Mori survey carried out in 2003, bearing in mind we've had a drop of 20% in alcohol consumption since 2004. The survey was funded and supported by Lundbeck. Lundbeck have produced a product called Silencro, which about 2 weeks ago was approved by NICE to treat people who've been drinking 2 large glasses of wine. You may have seen it in the press. It will help people cut down on their consumption. So do they have an interest in inflating the numbers? Does the drinks industry have an interest in reducing the numbers? The answer to both those questions is probably yes, but it doesn't make one right and one wrong. And I would say that the academic community also has to be equally careful. Future funding and reputation, and therefore future sources of income for both establishments and individuals, can come from further promoting a hypothesis rather than necessarily looking objectively at the science.
Well, you finished before even a yellow card came out. Thank you very much. On my immediate right, trying to chip in, so I can see I was right to sit you within snapping reach. Dr. Elizabeth Pisani has had an even more checkered career, I think it's fair to say. Having started reporting on politics and the economy in Asia for Reuters and The Economist, she then says, for years she trailed through red light districts and nightclubs. This was in pursuit of epidemiology, I should add, researching patterns of risk behaviour and HIV transmission, which led to her first book, The Wisdom of Whores, Bureaucrats, Brothels and the Business of AIDS. And I'll let her tell you a bit more about her points of view, which look like they're going to be spiky and interesting. But I can tell you that she's got an MA in Classical Chinese from Oxford, an MSc in Medical Demography from the London School of Hygiene and Tropical Medicine, and also from there a PhD in Infectious Disease Epidemiology. So you're a true Renaissance woman. Elizabeth, give us your 5 to 7 minutes.
So my Renaissance started at the London School of Hygiene and Tropical Medicine, where I went to do a master's, and I was in a lecture theatre about 3 times the size of this, first lecture, and everyone there is basically a medical student, a practicing doctor who've come to public health in mid-career, and I have a first degree in classical Chinese and a background as a journalist, so, which means, of course, I know everything. So the lecturer tells us the different study designs. To your point, different types of evidence have very different weightings and values. And then he asks a question, okay, so listen up, have you been listening? Why was it 14 years between the first Richard Doll's paper showing a case control study that showed the link between smoking and lung cancer, and the first US Surgeon General's warning about the dangers of smoking? And everyone's shuffling around and sitting on their hands. Lots of people, English isn't their first language. It's the first lecture. No one wants to look like an idiot. And I'm like, oh, God, that's an easy one. So I stick my hand up. He says, yeah. And I said, you're asking the wrong question. Low ceiling, sticky air. And he says, oh, well, would you like to, apparently med students don't do that, you know, so would you like to enlighten us? So I say, well, you know, obviously the right question is, how much money did British American Tobacco and Philip Morris give to US Senate campaigns in that 14-year period? Then there's a bit of a silence, and then everyone falls about laughing, and then, 150 hands go up. Because after you've done case control study, you have to have a randomized placebo-controlled longitudinal blah, 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 because only that will give you the evidence, blah. And of course, I felt this big. But I still kind of think I might have been a bit right. So, I think that one of the things that I realized very quickly is that public health man, who is these days usually a woman, is a different species from the type of man or woman whose behavior they are generally trying to direct or control, as you say. And there are 3 core beliefs of public health man, which I don't think stack up that well against human beings and their evidence. One is that the randomized, and they're all interlinked. One is that the randomized controlled trial is, by definition, the best form of evidence, and in some cases, the only form of evidence. Number 2 is that governments exist in general to do the greatest good for the greatest number of their people. Number 3 is that people are primarily concerned with their long-term health outcomes, and they allow their behavior to be determined by how their health is going to look 20 years from now. And number 4, in direct contrast with number 3, most people are idiots. Now, just to go through each of those briefly, the randomized controlled trial is a very useful way of testing pill A against pill B. But it is not necessarily the only form of evidence, and it is not necessarily the best form of evidence. So we have, at the time when I last wrote about this, which was some years ago, we had 497 studies that showed that giving out clean needles to injection drug users reduced the likelihood of hepatitis C, of HIV, it was cost effective, and it didn't increase other harms. And in most countries in the world, we still had a ban on giving out needles, including the United States with federal funding, on giving out needles with, to injection drug users. Why? Because there's another body of evidence, and that other body of evidence shows that if you do nice things for junkies with public money, you get voted out of office. So, to point number 2, governments do the greatest good for the greatest number of people. No, governments do what they have to do to get either voted in again, or if they're not a democratic government, to stay in power. That's the core purpose of governments. And that affects all the decisions they make about public health. So if you think that by banning smoking, you're going to look like a good guy and this and that, then you're going to go out and tap dance and say that we have evidence for this, it's evidence-based. But the evidence base you may be looking at is an evidence of political popularity rather than an evidence of science. People are primarily concerned with their long-term health. You know, of course, if you had the choice of, let's say, sewing T-shirts at 5 cents an hour rather than selling sex at $7 for 20 minutes, you'd always choose the sewing T-shirts because the selling sex not only is somehow degrading, but also puts you at risk for HIV. Well, you know, maybe that's not the equation that you're thinking about. Maybe the equation that you're thinking about is I need to do a job that allows me to pick up my kids from school and pay my bills while still being able to be a good wife or a good daughter-in-law, etc., and spend my time at home. So there are all kinds of choices that people make which are not necessarily related to their long-term health. Now, I keep giving examples like this because I've worked for many years on HIV, and, you know, if your choice is between getting high now or living a long and healthy life 10 years from now, the getting high one very often wins out. Most people are not idiots. A lot of, as you said, a lot of public health pontification believes that people can only absorb simple messages. So we, even where we have good evidence, we tend to hone it down into a very small number of simple messages. An example for HIV, you have to tell people that they have to use condoms all the time in all types of sex because there's always a risk of HIV transmission. I'm really sorry, but if you're on HIV medication, you're known to be positive, you're bottoming in anal sex, and you're using lube, you probably don't need to be using a condom. We don't tell people that. They figure it out for themselves. But we don't tell people that because we believe that we have to pull our messages down to the lowest common denominator because people are idiots. And poor people are especially idiotic. Well, in my experience, poor people and people who live on the margins are very, very good at making very, very sophisticated decisions every day of their lives about risk and managing risk. And if we gave people more information, they'd make better decisions. And those decisions won't always be about their long-term health, but they will be about their whole being as a person outside of public health nerd territory. Thank you.
I'm feeling deprived now. I'm not actually getting to use these red and yellow cards. I'll have to exercise fictitious power somewhere else. So finally, at this end of the table, the other Michael, who I shall refer to as Michael, Michael Blastland, has also been a journalist. He was a journalist at the BBC for nearly 20 years, where he did a lot of Radio 4 programmes, including analysis, and created the programme More or Less, which continues to do a fine job debunking statistical illiteracy, which was something people were very concerned about in an earlier session. More recently, he's written and produced A History of Britain in Numbers, which is, if you want a case study in how to relate large statistical knowledge to the life stories of individuals, I recommend you find that on podcast. And he's also presenting The Human Zoo about behavioural science, which is where I met him when they basically hired me off the street. He's written a number of books also, including The Tiger That Isn't with Andrew Dilnut about statistics, and The Norm Chronicles with David Spiegelhalter, with which I believe you have a copy there. So, Michael, give us your 5 to 7 minutes.
Thank you, Tamandra. I think somebody should speak up for public health, because it wasn't my initial instinct, but I get the feeling that it's the whipping boy today. So it is worth saying that public health has probably contributed more to human welfare than any other scientific discipline. I suspect that's probably right. And the great traditions, the noble traditions of public health, people like Snow and others, in discovering patterns of disease and the causes of those diseases, have been enormously powerful contributors to human welfare. There's been a turn, I think, readily acknowledged, most of the literature talks about this, in the patterns of public health study. From those initial widespread, often extraneous influences like the quality of the water that you're drinking, we've turned to what's often referred to as the risk factor. This is something that happened in around about 1980s, 1990s. We began to look far harder for behavioural, for example, behavioural impulses, behavioural characteristics, which were often at the individual level, which contributed in some probabilistic way to your likelihood of having some adverse health outcome. The risk factor is an absolutely fascinating notion. The principle I keep coming back to whenever I hear the word risk is that risk is seldom ever simply about risk. The temptation is to feel that it ought to be reducible to a set of quantifiable numbers, quantifiable evidence, probabilities of harm, and so on. This is almost never the case in the context of the sort of public debate that we have to have about risk. I'll give you a couple of examples. One is that the likelihood of fatality, if you take ecstasy, is comparable to the likelihood of fatality if you ride a horse. Now, that comparison is never really made in public argument, either to defend ecstasy taking or to decide that maybe horse riding should be subject to the same legislative control as taking ecstasy. But there's a reasonably, not approximately, the evidence is very hard to come by. You have to work out, it's a complicated calculation, so you're dealing with a very approximate comparison here. But it is approximately comparable. Now, why don't we have that debate? If we're interested in quantifiable measures of harm, and we can get, not a million miles away from reasonably quantifiable measures of harm, why don't we have that argument? In public health terms, I'll offer you another one. We talk at considerable length about obesity and smoking. We have readily identifiable objectives in most public policy arguments. What should we do about obesity and smoking? Generally, we have some good people who want to make us all healthier, and we have some bad people. We have some villains. We have big pharma. We have big food, big alcohol, Here's a curious one. We don't have Big Sofa. Why am I interested in Big Sofa? Because the risks of sedentary behavior are pretty comparable to smoking. David Spielhalter and I developed a little unit of measurement called the micro life, which takes the vast effects of all our bad behaviors and averages them all. And now there's some important caveats coming along in this thing, averaging aggregate behaviors and so on. These are tricky things. You need to be careful with this sort of stuff. But if you do that, and then you disaggregate it again to try and work out what it means in terms of the risks of daily behavior on an immediate level, you can say roughly how many half hours of life you're going to lose if you indulge in certain types of behavior. We call these half hours a micro life. So sedentary behavior, you sit down for 2 hours watching TV. We measure this very approximately. TV is a proxy for sedentary behavior. They are self-reported, subject to all sorts of caveats, all this kind of stuff. Sedentary behavior is about a couple of hours. Sedentary behavior takes about half an hour off your life over a 24-hour period. As I say, it doesn't precisely. This is an averaged effect of an aggregate measurement. So we can't tell precisely how much it takes off, but this is just a way of doing the calculation to make it immediate and present and personal. That's about the same as 2 cigarettes. Why aren't we bothered about sedentary behavior in the same way that we're bothered about smoking? Or in the same way that we're bothered about obesity? Where is the get up 5 times a day campaign? I mean, I think this is very interesting. If public health were simply interested in the science of reducing harm, it would be working its butt off to get people to stand up. And it is not. Why does it pick on particular targets and not others? I do think this is very interesting. One of the answers, I think, is that there is no enemy. You know, whereas with obesity, we can decide it's the food manufacturers, and that's motivating. It's also quite simple. It also suggests an obvious legislative response. You attack these people somehow. You control what they do. You control what they offer. You demonize them. You make films about the men who made us fat or the men who made us smoke or whatever. Enemies are useful motivating factors, you know. But these enemies are also enemies in other contexts as well. And that, you know, we don't need to lose sight of that. The kind of free market behavior, the actions of industry to impose, so it said, certain things on her. Forget that there may be kind of choice involved in any kind of market transaction, but these things are imposed on us, supposedly. All these things contribute to our notion of what's the sort of risks that we want to go for and the risks that we want to accept now. You know, I don't want to make too much of this, because, you know, in one sense, trying to legislate about sitting down is a kind of fatuous suggestion. But it does, I think, help us understand what's going on in a concept like risk. That it is not simply about quantifiable measures of harm, but it is a bundle of politics and morality and philosophy and views about what's valuable in life. And all these things are packed in to any argument that we have about our own lifestyle, about appropriate public health measures. My problem is whether to just let that go and say it's all politics, what the hell, or to say that public health ought to try to distinguish more carefully than I think it does between the politics and the philosophy and the moral objectives and the reasons why you do go for smoking and the evidence, the quantifiable evidence that we, you know, an enormous amount of effort goes into finding quantifiable measures of the harm of these various things, approximate, as I say, averaged, flawed in all kinds of ways, but nevertheless the best we've got. Now, until we do begin to separate those kind of things out, suspicion, I think, will always be there that people who pretend to be talking about science are really talking about one of the other factors that's bundled up with the notion of risk. Quite often I think that's the case. And the whole package will be rejected. Now, I don't know whether it is possible to separate the stats, the evidence, the research base, from the politics. I don't know whether you might just as well say, look, let's bundle them all up and have the whole argument all in one, or whether you really should work a lot harder to distinguish the two. But I know, I'm pretty sure that there's little self-awareness amongst some people in the public health argument that that's what's going on. I think they do feel that the science leads inexorably to a certain set of policy prescriptions, and they tend to avoid the more complicated arguments that should take place. Those arguments have to take place because risk is not a purely quantifiable statistical exercise. It is packed with just about everything we value and hate in life.
I'm going to have to play devil's advocate and throw back to all of you nuanced, insightful, critical panelists that I've gathered. It's all very well to say, well, we have to distinguish between the evidence that you're going to lose the election and the evidence of what harm will be done. But fundamentally, because a lot of public health now is about behavioural things, it's about risk factors that are to do with our own personal choices, does that not mean that if we want to continue to extend the human lifespan and health and well-being, that inevitably that's going to involve getting people to change what they do? And so research into what gets people to change what they do should surely have an equal status with the epidemiological studies that say, oh look, we found doctors who smoke are 10 to 50 times more likely to die than doctors who don't smoke. So convince me that we shouldn't give equal weight to evidence into what works in campaigning terms. So what if we simplify a message? I mean, you've argued that it doesn't actually work, but if we get a message like 5 a day pieces of fruit and that works, what's wrong with giving that evidence the same sort of weight as we would give to Donald Hill's study?
Well, I think if the evidence is good, then I think there's a case to be made on a case-by-case basis. The problem is, I mean, for example, the evidence that there's a link between cigarette smoking and lung cancer is very strong. And as Elizabeth said, there was a considerable delay in the presentation of public information about this. The public information was disseminated, and it had a dramatic effect on the public level of smoking. Smoking dropped between the early 50s down to what it is today, roughly about 20-25% of the population. People are informed, they could take their choice about that, and they have done that, and where there's a very clear evidence for it. What's interesting, just two things about that. One is that the evidence for the efficacy of any of the more intrusive and coercive and shaming and stigmatizing measures that are introduced over the last 5 years having similar effects is very poor. If you notice, the levels of smoking of young people have remained remarkably resistant to all this propaganda, which has had the effect of stigmatizing and turning smokers into a pariah, and even the legislation against passive smoking. It has not very, if you compare the fall that took place in the earlier period with the fall that's taken place over the last 10 years, it's much less. The second point to be made about that is that a similar level of causative relationship between any other factor in the way that cigarette smoking is linked to lung cancer and any other ill health has never been established. This is the great holy grail of epidemiology. The hope, it was so profound. Look, it was a brilliant thing that Dolan Hill did. They showed smoking caused lung cancer. There must be other causes of other things that we can prevent in the same way. Unfortunately, this has not been proved to be the case. The relationship between all these other factors, dietary factors and health, exercise and health outcomes, is very weak, very complicated, and not scientifically well established. That's the first problem with that. The second problem is that the evidence supporting the notion that any intervention produces the desired objective is even weaker, because that's the other great thing of wishful thinking. Everybody hopes that if you could just tell people that if they ate 5 or 10 a day, 5 a day fruit and veg sake, which is actually, for which there's very, very weak evidence, but if there was evidence that if you tell people that it actually, or give it to kids in schools, that it actually produces the desired effect, either in terms of them eating 5 or 10 a day, which it doesn't, or in terms of improving health outcomes, which it doesn't on large-scale observational studies, then it might be legitimate to introduce it in public policy. But it has been introduced as a public policy in the absence of any of these things. That's what I object to.
But surely that's an argument for actually researching into what does make people change their behaviour, because if just telling people the facts doesn't make them change their behaviour, is that not an argument for precisely things like the Behavioural Insights Unit, whose job is to research into what does work in getting people to live healthier lives?
I think that Henry made a very important point, which is that it's going to work differently for different diseases because we have different behaviours with different motivations. So diseases that are related, I keep coming back to sex and drugs because that's what I do, but
that's going to go down as the best line from any speaker this weekend, I think.
But seriously, diseases that are to do with pleasure, diseases that are to do with, which smoking-related diseases are one of them. Why do people smoke cigarettes? Because it gives them pleasure to do so until they're hooked, and then it gives them, you have a physiological need to keep up your nicotine levels. But it's you've created a dependency through pleasure. That's going to have a completely different, potentially, set of behavioral triggers than obesity or various other things. So it's deconstructing. It's not to say this type of behavioral intervention works. Stigma doesn't work. And whereas shaming doesn't work. Well, actually, I would say that stigma works pretty well in against smoking. I mean, I smoke much, much, much less frequently in this country where it's very highly stigmatized than I do in Indonesia where there's no stigma attached to it at all. I think stigma works pretty well. It's kind of embarrassing to be the only person at a North London dinner party who has to slope outside in January to, have a quick fag. So you don't do it. Stigma does work, but against HIV, does stigma work or not? Well, that's a whole different discussion. But I think that, Henry's point is an important one, that we can't think in the same way about behavioural campaigns as we used to be able to think about interventionist campaigns to do with ensuring a clean water supply or universal precautions for safe blood in hospitals or things which are much more mechanical.
But again, doesn't that just suggest that we need to turn? Now we pretty much know what the risk factors are. Okay, most of them are smaller than smoking. You might like to come back on that when you're with your campaign against Big Sofa. But they're smaller, but they can still have an effect. So surely that means we need more research into how to get people to change their ways for their own good. Henry, speak up on behalf of the Behavioural Insights team, or the Nudge Unit.
I think there are a couple of, we haven't talked about a couple of things. One is the kind of permission that you get. So I would say that there's a difference between getting permission from me, who doesn't want to wake up tomorrow morning with a headache, and I can make some choices today that will help me have a drink this evening and not wake up tomorrow morning with a headache, over then extending that to this room and then extending that to a town, or then extending that to an entire national population. And I think one of the things we forget is that when the degrees of evidence get weaker and weaker and weaker, or stronger and stronger and stronger up and down the list, then you have less permission from people to be more interventionist. And exactly your point is that that's where the politics comes in. Actually, somebody somewhere is making a decision, and it becomes a political decision. So I hear often, well, this is the best available evidence. Well, if the best available evidence is a predictive model, we have to be really, really careful that that's sufficiently good evidence to attach to a national, population-based intervention. So I would come back to the nudge piece. Is if the thing that I think a lot of people also forget is that it may be that there have been random controlled trials carried out in controlled settings, usually within universities, around how much you eat compared to the size of the plate, around container sizes, setting parameters for consumption around social norms and so on. What we do much less of is look at those in the big, wide, complex world and say, well, what are the unintended consequences, or what will happen if we squeeze this part of the balloon and we affect behaviour change here? Will it not pop out in another different direction? And I think sometimes when we look at, as I just mentioned, the difference between a national trend around alcohol harms, we actually see that the same trend is prevalent for smoking, in terms of, if you look at the northeast versus the southeast, if you look at obesity, you look at alcoholic liver disease, and you see that actually there are other very complex factors at play which actually show that whilst people in the northeast drink less than people in the southeast, they suffer more harms. They suffer more smoking harms and obesity harms as well. So I think, my point really is that if we really get back to the heart of where public health intervention started at a community level, then they have more permission and they are stronger. And I think people will then go on that journey more with them.
So Michael, Can we make a distinction between research into how effective it would be to use a certain poster campaign to stop all these people smoking and drinking, and research into what the medical effects will be if they do indeed stop?
Well, it does sometimes occur to me that the most energetic voices in public health are not especially interested in the efficacy of their solutions. And that sounds like an absurd thing to say, but there's a preference to ban things, to legislate in some way, to restrict, to control. Now, you know this because you did the report, but there's a pub in South London. Well, it looks like a pub, but it's actually run by the psychologists at University College London. And they do things like put up posters saying, don't drink so much, you idiot, you know, it's going to kill you. And they produce stats and so on, and they're very kind of powerful. They're as powerful as they can make these things, right? Deterrent, prohibition, do not do this, it's stupid, it's going to kill you, sort of stuff, you know, more sophisticated than that, I'm sure. But that's essentially the tone of the message. Drinking goes up. Now, that's extremely interesting, but I don't observe much interest in it amongst the public health professionals advocating bans, regulation, control, and so on. And there are a number of problems here. One is, I think, you know, you're absolutely right that there are differences that emerge between different groups, different habits, different regions. There's also the problem, which I think has also been hinted at a little bit here, that the predictive power of most of what we know about epidemiology, I think we know slightly better in some areas than might suggest, you know, certainly for smoking, but I think some of the evidence is not entirely flaky on some of the other areas. Approximate, though. The difficulty is that the predictive power is extremely low at the level of the individual. So we know at population level that quite a lot of these things might have quite big effects. We can talk about 10% increase in risk for this, a 20% increase in risk for that. But the baseline risks are, in any case, often quite small, so a 10% or 20% increase is not much. It might affect the number of people rolling up in casualty, and from a national health point of view, you might be quite interested in that. But from my point of view, or your point of view, your individual point of view, saying, what are most likely to be the outcomes for me? It makes hardly any difference. Now, those things can be perfectly compatible, that you can have large-scale population effects and almost zero effect on your personal probability of suffering some kind of adverse effect.
And that's to assume that you're even thinking about the probability of suffering some adverse effect. Whereas after I've had 7 glasses of wine and I get on my bicycle to cycle back across London at 2 in the morning.
You cycle across London? Are you crazy?
There you go. You know, I do it even when I'm sober, which is bad enough. But when you're pissed, it's really stupid. But you do it anyway because, well, look, I mean, if I were to take my epidemiologist glasses, I would say, okay, there's a very strong correlation between me being that drunk and there being no public transport left. And there's also a strong correlation about me writing non-fiction books and me not having enough money to afford a taxi. And, you know, you can do your associations any way you want. But the fact is that most people at the level of individual behavior are not spending a lot of time thinking about their long-term health risks. So what does that mean for the public health community? I think it means that what you have to do is try and align your goals, because the goal of the public health community, you said, if we want to make people live longer for their own good, I mean, listen to yourself, you know, if we want to make people behave better for their own good, for their long-term survival, then why don't we start thinking not about getting them to do what we want them to do, but getting them to do what they want to do, and have that be in some way aligned with our incentives. So why do needle exchange? So I come back to HIV because it's what I know best. Why do needle exchange programs work much, much better than condom promotion programs in much of the world? Not because injection drug users are more scared of HIV than sex workers are, but because actually it's no fun sharing needles. In the same way that you don't share a toothbrush with someone that you're sleeping with, you exchange body fluids all the time, but you don't share their toothbrush because that's just ick. Same thing with needles, you know. But so the evidence, I want them to use clean needles because I want to reduce disease transmission. They want to use clean needles for completely other reasons, but we have shared objectives. But if you're a gay guy in a club who's on a 4-day Tina-crazed binge, you know, the idea that, you know, my desire for you to use a condom to reduce the risk of HIV or other sexually transmitted infection is somehow aligned with your desire, it's just not in that instance. So what do we, so as public health nerds, I think that we have to think about what motivates people's behaviors and think about how we can align their goals with ours or our goals with theirs rather than just try and force them to accept our goals.
They are now.
Rant over.
Now I've been called out as an authoritarian public health nerd. I feel it's time to come out to the audience. As you see, although I've assembled a brilliant panel, they're regrettably united in their desire to be nuanced and reasonable. So I hope that you're going to give them a hard time and give us some opposing points of view.
Yeah, I just wondered why the panel think that health and the body has become such a primary source of meaning for people, both for government, public officials, civil servants, and then individuals in general. I teach undergraduates and recently ran a seminar with 20-year-olds on health, on the concept of health, and asked them whether they thought they were healthy or not, and they all thought they were unhealthy. And I said to them that you're probably the healthiest you'll ever be, and you're the healthiest that human beings have ever been. And yet the things they worried about when I asked them were, they think about their health every time they eat a meal every day. They worry about how much sleep they get or don't get. They worry about the fact that they don't go to the gym. And they worry about how much water they don't drink. And what was really interesting was their disconnect between the rules that they thought they knew, although they didn't know any evidence or why they were supposed to follow these rules. When I said, how much water is it supposed to be? They said, I think it's 2 or 3, maybe 4 litres. Why are you supposed to drink this water or not? You know, they had no idea why that might be. It's to flush things out or something. And that hasn't come from a public health campaign. That's come from magazine supplements or whatever it might be. So I just wonder why you think it is that it's, you know, people are anxious for the rules, but they're not completely unable to follow them, and where that leaves us, and whether we end up in a very bovine state, where we are the kind of objects of public health campaigns.
To go on from what the last person said, it seems that public health is not restricted to public health nerds. Almost everything anybody does has to in some way incorporate a healthy option or to incorporate, and it's invaded the policy of going far beyond what you think was normally health. For example, we all have to drive at 10 miles an hour slower in Brighton and have Brighton dug up because Brighton's so keen on getting people to cycle because it's healthier. And actually, looking at the evidence they've got for saying they have slowed down the traffic, or they don't say they've made anybody healthier. They say we've slowed down the traffic, we've made them healthier by not having less accidents or something. And there's no evidence for that either. A phrase I think Tamandra heard when she was down in Brighton, that are we actually looking at evidence-based policy, or is the policy driving the production of the evidence, or driving where to find or cherry-pick the kind of facts that will fit with what you want? There's so much evidence provided by health and related industries that it affects everything. Road safety, council-approved aromatherapists, you know, there's all sorts of things. It bleeds out into a kind of a whole mission creep of health, covering everything in its dead, clammy hand.
As a healthy attitude.
A number of panellists have made an important distinction between the data that actually support various claims and the data about what kinds of data influence people in making decisions about health. I wonder whether anybody had any thoughts about what implications this might have for the ethics of deception in public health, or at least giving information which, although it may not be false, is certainly misleading. So, for example, I've often seen in clinics a poster that says something like, let's face it, we all smoke, meaning we all smoke passively if not actively. And then it says that if you live a life of passive smoking but not active smoking, you have a 25% increased risk of getting X, Y, and Z diseases. Of course, what the poster doesn't tell you is that we're talking about relative risk and not absolute risks. So if the original risk is, say, 1 in 1,000, you add 25% of that to 1 in 1,000, you have a 1.25 in 1,000 risk of getting that disease. Yet people see this, they go away thinking, help, I've got a 1 in 4 chance of getting lung cancer. if I smoke passively and don't smoke myself. Now, I wonder whether the people who put this poster out know this perfectly well, but think it would not be good propaganda if you actually got it in perspective. So there might be a deliberate attempt to get it out of perspective. Now, I suspect that's what's going on, but the question is that justified? Maybe there's some justification for deception for the purpose of public health. I don't know.
A bit of defence of the public health to remind people that the association between smoking and cardiovascular disease was very strongly demonstrated in Dole and Hill. To agree with the point that we shouldn't make our messages too simple. So that, for example, in terms of needle exchange, it doesn't matter whether an injector injects with a clean needle or a dirty needle, the risk of overdose death is the same. And in Scotland, in 30 years of HIV, from all exposure categories, there were 1,894 deaths from HIV. In 5 years, 2006 to 2010, there were 1,970 opiate-related deaths. We do need to get perspective. We do need to get the numbers right.
Well, there's two very simple questions. One is to echo a question asked down here, why is public health so prominent? But what is the state's interest in public health? I mean, the most obvious ones would appear to be having a functioning workforce and having a functioning armed force. Now, clearly there's more than that going on. It's interesting to consider what and why. May sound obvious, but I think it's worth asking. The other thing worth asking is why it's so common for health to be seen as an end in itself rather than a means to the end of people having the sort of life they want. Health as a means to an end of a life that may include or may not include the big sofa and big burger. Would that not be a more basic courtesy to consider health that way? And if you don't consider health that way, that suggests either that you don't think people should have what they want, or you think that people don't know what they want. And that's an interesting thing to debate, if so.
I've worked in many different countries around the world, and the question of the state's interest in public health is greatly dependent on the state's investment in health systems. So in a country where you have a national health service, you tend to have much greater investment in public health, by which we tend to mean preventative health measures, because it makes perfect sense to invest in that so that you preserve your investment in curative services as much as possible. And there's a very, very clear difference between, for example, the UK and Australia, France, countries that have largely publicly funded health systems, and the United States, which actually has a very poor record in terms of public health in general. So I think that that's a very big part of it. And I think that to a certain extent that answers slightly your second question also, which is, well, why not big burger, big sofa? And if that were entirely a personal choice, I tend to agree with you, but now you're in a situation where, wait, I pay to go to the gym, and then out of my taxes, I also pay for your treatment for ischemic heart disease because you've been sitting on your butt eating big burgers. So where there's a shared financial responsibility for the outcomes of poor health, there's more of an impetus, I think, for government to take that role in somehow trying to control and limit poor health, and there's more public support for that role. Okay.
Just in response to the deception question, the good lie, the noble lie, is a dominant theme in public health, and I think this goes back most clearly in this country to the HIV/AIDS scare in the late 80s, early 90s, and there's a famous article published 10 years after that, reflecting on this, made the point that they lied to us, but that was the right thing to do because it scared people into changing their sexual behaviour in a way which was claimed to produce great benefits. Actually, I think it's highly, and Elizabeth has written on this, that many people in the AIDS world subsequently recognised that the grossly exaggerated statistics that were used of that were effectively a good lie. But that's widely accepted. I think that's become a principle of public health. If the cause justifies it, is the idea that if it will scare people into changing their behaviour, then it's justified. I don't think it's justified to deceive the public in that way, even actually if it did achieve any of the objectives. I think it's highly doubtful whether it did. I think it has a lot of very significant negative effects. But we see that in the passive smoking discussion. The good lie dominates that too, because every epidemiologists in the know that the evidence is very, very weak in that area and very contested. But they say, oh, but if it discourages people from smoking, fine, we won't look at it too closely. I entirely, just in the point about Doll and Hill, I accept Doll and Hill demonstrated a relationship between active smoking and cardiovascular disease, no doubt about that. What Doll himself, I was at the lecture when Doll presented his 50-year follow-up. It was a very unusual thing. He presented a paper 50 years, he died shortly afterwards, well into his 90s. And Doll himself was very sceptical about the claims that were made on passive smoking. It was and in fact, they had to keep shutting him up because he kept on blurting out, this passive smoking is really a very weak argument. And if you want to look at and that's even in relation to lung disease in relation to passive smoking. The issue of the contribution of passive smoking to cardiovascular disease is a subject of even more contentious controversy. If you want to check that out, the book by Jeffrey Kabat and James Enstrom, who published a paper that actually demonstrated that passive smoking made no great difference to cardiovascular disease, but were savaged and almost Jim Enstrom was more or less driven out of his job. He's a jobbing epidemiologist. His results didn't happen to fit in with the consensus because it didn't fit in with the good lie, and he blurted it out in public and was very viciously censured as a result. On the good life question, I think obviously this is a very wide and the expansion of health, which people pointed out. I think there's no doubt that in modern society there is a sense of people being turned in on themselves and a sense of a lack of partly to do with some of the general discussion about the contraction of politics. People aren't really doing anything out there in the world. They're turned in on themselves. People are more individuated. And at the end of the day, what have you got left apart from your body? And so people are preoccupied about their body. And they're preoccupied with slimming it, with exercising it, with tattooing it, with piercing it, with plastic surgery inflicting on it. The body is the aim and objective of everybody's life. Well, I can tell you as a doctor, the body will let you down. It will. Doctors know in the multifarious ways in which the body will let you down. And if you devote all your energy to that, it will be very disappointing and demoralizing for you. And that's why, actually, this cult of well-being is actually a cult. It makes people ill. That's the really unfortunate thing about it. It contributes to illness.
Yeah,
Sorry.
So, Michael, are we too obsessed with our bodies?
How do you quantify that one? I'm not sure. What would the evidence be for degrees of obsession?
The greatest heart-sink words in medical practice are when a 25-year-old person comes and says,
I
need a complete checkup. Yeah. Why?
I mean, I can give you a partly economic explanation for the fascination with health, which is that it's a premium good. So if you look back historically, the things we spent our money on were subsistence. You go back far enough, we spent all our money on subsistence because subsistence took all our money. And the fact is that, you see this in every developing economy in the world, that is, as we become richer, we tend to spend more and more, a larger and larger proportion of our income on health. Because there's almost a cap on how much you can spend on food. Well, maybe the obesity argument might disprove that, but in general, the area for additional discretionary spending is on the things which we value most. So this is slightly circuitous answer. Why do we value them most? But economically, we always seem to have spent more of our increasing disposable income on health. You can see this in public expenditure, and you can see it in private expenditure as well. So there's a kind of an interesting argument about why health should be the premium good, that it is, and that it has been almost forever, I think is pretty hard to argue with. I'm interested in, this is complete speculation, there's no evidence for this whatsoever, but I am interested in the sense that I do think I come across increasingly that life can be optimized. By that I mean that we have such a strong sense of the causal relationships between everything that can be discovered through science, probably an exaggerated sense, that we feel if only we can sort out every environmental influence, if only we can get every life choice right, You know, there's a kind of sense of perfectibility out there somehow. We dare not allow our children to be in a class where the teacher is less than perfect, where where the attention of all the other students, because if there's one naughty boy in class, that's not good enough. You know, this feeling that everything can be nailed down to the utmost benefit of ourselves and everybody else. You know, this curious feeling of optimization. And what that ignores, I think, is what some epidemiologists call the non-shared environment. So you look at the causes of bad outcomes. Some of them are genetic. We can do a reasonable job at trying to identify some of those. Some of those are environmental, like your decision to smoke. Some of them are non-shared environmental factors. What does that mean? It means chance, accident, happenstance. There's a story I like telling in this respect, which comes from crime, which I'd like to make the radio program one day, called Mike Tyson's Brother. You say, what are the influences that make Mike Tyson the person he is? Misogynistic and violent. You say, well, you know, he came from a family with a lot of drugs, a lot of violence from the parents, whatever. You know, it's that kind of family. It's not surprising he turned out like that. And then there's Mike Tyson's brother, who is a trauma surgeon in California. You say, well, I know all the environmental influences and I know the genetic association, so why these astonishingly different outcomes? And the truth is that in life, chance is quite capable of obliterating everything else we think we know about the causal factors. You know, I mean, it's the proverbial, you could be run over by bus tomorrow, but it's deeper than that. It's not just the mortality, it's every life course can be affected by what? Some chance conversation in the playground. Just last point. George Davies Smith, who a terrific epidemiologist, I think, who writes a lot about this, says did something about a smoker called Winnie. She'd hit 100 and she was alive, you know, and there she was celebrating, lighting a fag off the birthday cake, you know. And they say, well, why is Winnie alive? This is outrageous. And he said, well, imagine one day she has a cell at the back of her throat which is turning cancerous. And there's a knock on the door, and it's the postman. And she opens the door, and there's a strong gust of cold wind, and she coughs, and she dislodges the cancerous cell. And Winnie never does get cancer. And I think we've slightly lost a feeling for the random, and the chance, and the unpredictable, and the non-linear causal and the multiple causal and the mess and the confusion that envelops all of us as we kind of try and model our way through from beginning to end. And I suspect that has something to do with the kind of premium that we all place on a manic pursuit of health these days, because we think we can control it, and we can't control it as well as we think.
Henry, respond to any and all of that.
Well, I was going to respond to two, why public health is so important and this sort of ethics of deception. And I was completely going to agree with you around, you know, the NHS. Actually, if you go and look at the two major political parties, they're fighting over who cares the most about the NHS, and when that is so high up the political agenda, and as you quite rightly say, that the argument has been largely won as to whether prevention is better than cure, and therefore when you pile those things together, and the third element being, you know, we all want to live a longer life, and sometimes people forget the really important element of that, which is quality of life, but we want to live a longer life, and you pile those things together, and that starts impacting on why public health is so important. And then you overlay something else, which is that we live in a consumer environment, and I was just thinking through the types of organisations that care about this then, that would then take your question and would build that up. So we're talking about the press, the magazines and newspapers that want to play this game. We look at the active leisure industry, we look at the skincare industry, we look at the the oral hygiene industry, we look at the industry surrounding universities and higher education, and we suddenly realise there are lots and lots, and I've just listed a few, but we realise there are lots and lots of people with an interest in increasing the visibility of public health in lots of different guises for commercial reasons, quite frankly. not to mention the industry that I work with. But I think there's another element to this, and there was a study carried out by Robert Cialdini, which comes back to the other element, if you like, around the ethics of deception, which is we have to be really, really careful, and he describes it as the policymaker's big mistake, which is if we elevate something which is relatively small and we give it a greater and greater and greater prominence, then it will by definition grow. And one of the examples used is around knife crime. And actually the very, very, very small proportion of young people that carry knives. But if it's all over the press and how bad knife crime is and how much worse it's getting, then young people start going, well, blimey, maybe everyone is carrying a knife and I need to carry one. And actually putting things into perspective and really coming back to the point that we are living longer than we ever have been, we're living healthier and longer than we ever have been, and put that into perspective, I think is really important. I think that comes a little bit, was it your question around the ethics of deception? It is well known that if you get your campaign into the media, you get more prominence for your campaign and maybe for whatever funding or marketing that goes with your campaign. And it's not necessarily a helpful thing, I don't think.
Okay, as we can see, the panel have loads to say, so what I'm going to do is take all the questions I can.
Fiona Fox, Science Media Centre. Is it just me? I was on a panel with Spiegelhalter last week, and I love him. But he did the stuff on the stats on the bacon sandwiches. If you did the worst and ate 3 bacon sandwiches a day every day of your life, you would lose a year. And I do love David, but he seemed to think that was very significant. And I'm just, and alcohol as well. I mean, I love drinking. I love alcohol. It gives me huge benefit. And people who worry about me tell me that I will lose 6 months off my life. Whereas with smoking, I think you're right. With the big killers, heart disease, smoking, HIV, you were losing 30 years of your life. That was a pretty big incentive. And another quick one, our CMO, our Chief Medical Officer, has said recently e-cigarettes are the biggest threat to health in the decade, and the evidence on sugar will show that it's addictive. She said both of those things to select committees. I don't think she's political, Mike. I don't think it's about winning elections. I really don't. I think she's a good epidemiologist and a good health person. So what is driving that? Is it that it's popular? What's that about? The evidence hasn't even been done and she's telling us what it'll say.
Most or all of the interventions that you've talked about are about individual behaviour, but actually there's a lot of public health interventions which are not about individual behaviour at all. So leaded petrol, or mosquito extermination, or folic acid in cornflakes, or fluoride in the water, or smallpox vaccination. Well, that might be a slight bit about behaviour, but there's a lot of public health interventions which are not just about changing individuals' behaviour and trying to persuade them to do things. So I wondered if you could talk a little bit about those and how those relate.
How they fit in.
Yeah.
Good point, thank you.
I just wondered to what extent you think about the potential negative effects of some of these interventions or messages. So when we talk about things like the good lie, there's an assumption that there's only sort of benefits to doing that, therefore it's justified. I thought it was a really interesting point about the sort of 20-year-old students, undergraduates, being so worried about their health, because what it seems like is that you create an awful lot of anxiety about health, which is really potentially negative. An example I'm thinking of from recently is a study that showed that women who discovered they're pregnant and who had been drinking alcohol up until the point that they discovered that they were pregnant are increasingly requesting abortions because they're so worried about the potential negative effects that they might have had on their unborn baby at that point. So obviously that's something that's potentially a very negative effect, but the chances are the level of risk in most of those cases is probably absolutely minimal, but the message that's got out there has created a huge amount of anxiety. Other examples I can think of are the sort of messages around breastfeeding. So I'm aware of friends, lots of friends who've got young children, and I'm aware of friends who have said it's got to the stage they had to return to work and wanted to continue breastfeeding, so they were spending so much time pumping breast milk so they could carry on feeding. So if not having to go to formula because they were so concerned about this because of a really strong public health message about this, that it got to the stage they couldn't interact with their own baby. They had to sit with the baby at a distance, not interacting, spending hour upon hour pumping breast milk. And you have to think that the longer term, and sort of realising that that's ridiculous, probably the longer term benefits of interacting with the baby is going to be much, much greater than, not using formula milk. So I just wonder how much we consider these things and how much it just creates a very sort of negative, anxious sort of atmosphere.
We were talking earlier about risk factors and how people cherry pick their risk factors. If you look at one of the risk factors for many of things like the abuse of alcohol or for obesity, the largest ones is poverty. So there's a social element to it. And I was wondering what you think about the fact, I don't think that one ever gets picked, because if you pick the other ones, the ones that focus on the individual, that allows you to recruit the effective element if you're a politician. It allows you to moralise. Just to bring it back to the judgment, which is the point of this weekend, it allows you to set it up so that people are judging other people and that sort of motivates them to go, oh, I want to be part of this, I don't want to be part of that. But it doesn't actually address one of the larger risk factors. If you wanted to be a scientist about it, you'd find out what's the biggest single risk factor, let's go for that.
I think the state's interest in public health is as the post-political common good. So the kind of model for public health is a purely physical, purely passive subject, and who is acted upon from above and without. And so it's for that reason I'm quite heartened by the fact that people that are resistant to these measures and make what Nudge finds to be suboptimal decisions. Because I think that really what that tells you is that in many ways the importance of feeling alive and justifying one's life outweighs the importance of staying alive. And that has been the case since Achilles, who was given the choice between living a long and inconsequential life and dying young in glorious death, and he chose the latter because feeling alive is more important than staying alive. I think that remains the case today, which is heartening.
There were 2 points that I want to make. One is about balance. Michael mentioned there's a big element of the unknown, the chance factor. But I think, within the chance, there is a question about balance as well. We all hear stories of people who smoke up till 80, 90 and live happily and healthily. But what we don't read about is what else that they do in their life other than smoking. They could be exercising regularly. They could have a very healthy and happy family life, which are all good, all contribute why they've lived up to that age. And it is important to think about balance, because balance is something that we can control, whereas chance is something that we cannot. The second point I want to make is about cost-benefit analysis. I think too much information or over-discipline could be counterproductive. I would like to ask the question, is the reduction in sugar intake really worth the stress of calorie counting in every supermarket? I've been a smoker for a long time, and sometimes one comfort I get is if I wasn't smoking, I could be doing a lot of other things that's a lot more damaging to my body, actually.
Well, it's not as if there aren't still quite a lot of public health issues to sort out. So in Scotland, you've still got lead in piping. You get massive roadkill on, the major road, but up to Inverness. You still get hospital infections all over Scotland, etc., etc. There are plenty of public health issues, but actually the politicians have just cut spending to public health in the NHS in Scotland, cut down on both the numbers of public health specialists and the funding thereof, but they have a major, major campaign on all the things that have been mentioned today. They led on price increases for alcohol, they led on all sorts of other lifestyle issues.
I think the point Henry made, people say prevention is better than cure, and I think I would agree with you. The trouble is, it's not the cheapest way still. And actually, for many things, curing is cheaper than prevention. I mean, a heart bypass is $10,000. The amount of money you have to spend, or somebody has to spend in the system to prevent that is often more, much more than that. And that's part of the mistake. We will eventually get to the point where, in many cases, prevention will be better than cure. But in many cases, that is not the case at the moment.
I run British Pregnancy Advisory Service, and we were responsible for putting out this information about the panic about drinking in pregnancy, resulting in an increased number of requests for abortion from women who were worried that they had been binge drinking in pregnancy. And I have to say, it was something that I kind of really worried about doing, because I was a bit concerned that it might be replacing one panic about drinking in pregnancy with another one about women requesting abortions, you know, on a whim. We thought it was important because we know that about a third of babies that are born are not planned, and we know that we do see in our clinics a whole number of women who feel that they need to at least investigate the option of abortion because they're really, really worried about stuff they've done in pregnancy. So it is a genuine concern. But what really interested me was the response, and the response to this point that we had put out, which was a kind of way to mitigate an article that had been widely published in the papers saying that one episode of binge drinking in pregnancy could affect your child's performance until the age of 11, which has got to be the most bollocksy use of statistics, you know, you could ever possibly imagine. But it was quite interesting that the response that we got for putting out that information was very strongly, you can't say that. Why can't you say that? Because you're confusing the public health message. Why is it confusing the public health message? Because it's a lot easier to convey to women that they shouldn't drink anything in pregnancy than to give them nuanced information. Now, what I'm not sure about, the question that I wanted to ask is, you know, is this part of what Mike described as being like the big lie, that the whole public health kind of sector, particularly the nudge unit, is really okay about perpetuating stuff that it thinks are good lies? Or is it that they genuinely believe that women are so stupid that they can't handle nuanced messages about things? Because it just seems to me that from a sheer public education point of view, appearing to support studies that have just got this huge bollocks factor to them just can't really be even giving the perpetrators of them any credibility.
Hi, my name's Andy Wilkins. I do management consulting. No kisses and booze, please. But I've romped around the health service quite a lot over the last few years. And I was in Bupa a couple of years ago, and we were doing some research on behaviour change. And so I wanted to pick up this point and perhaps emphasise one of the points you made, Elizabeth, which is that when we did research, we brought in a number of people to really understand what was it, or see if we could divine what were the sort of key things that lay behind why some people were able to successfully change their behaviours and others fell off the wagon. And there was some really interesting insights we got from that. But one of the key ones that we found was that the people who were able to sustain long-term behaviour change had successfully managed to both understand their health and map that to goals that meant something in their life. So the guy who was concerned that he wasn't a good father because he always arrived home too tired to be a good father, recognized he needed to improve his health, improve his diet, and he was motivated to do that and sustain that. The woman who stopped smoking did it because she was aware that her stained teeth was affecting her ability to find someone to go out with. So the ability to successfully map health behaviors to goals that meant something in people's lives seemed to be the magic sort of formula here. And I worry sometimes that public health, with its sort of one-dimensional lens of stop smoking, stop doing this, is basically making people aware, but people have such ingrained habits and routines that to stop doing something because I shouldn't be doing that is something difficult to sustain over the long term. People fall off the wagon. If we have a more intelligent public health 2.0 that allowed us to help people understand how health behaviours sustain and support the goals that matter to them, I think we'd have much more success, and I just wonder what your thoughts were on that.
Let's go in reverse order. So let's start with you, Michael.
I think I agree with almost all of that. Is that good enough? Is that correct? I think there's so much wisdom in those answers. I really do. And I can't help mourning the fact that it isn't out there in the in the media and in politics and in Parliament and elsewhere. And it comes back to the point, how stupid people are. They're not. Particularly this point, when you can make it consistent with the other goals and values that they have in life, it works and they'll understand it and they'll change and they'll take the data in and all the rest of it. I think there are good examples where people reject data even when you slam them over the head with it, but they do it for a reason very often. So, well, what do we do?
And
we get them all. We get them all. We make them all come to the Institute of Ideas, I suppose. For their own good.
They are their own good. They all have to come to Battle Ideas. So that makes you next, doesn't it, Elizabeth?
So the first question about the value of extra life, I think is an important one. This whole discussion has been predicated on the idea that a long life is necessarily a good thing, and that there are a couple of questions that have questioned that, and I also question that. I remember being in Australia many years ago, and the Public Health Foundation there was giving a presentation to public health foundations from other countries, and they said, we'll show you the numbers, and we're doing so well on our campaigns. I'll show you the numbers now and what we're predicting for 20 years' time. And the numbers now are, for women, #1 cause of disability, loss of disability-adjusted life years, so basically mortality and morbidity, is smoking-related diseases. After that, it's ischemic heart disease, traffic accidents, sexually transmitted infections, blah, blah, blah. But we're doing so well that here's what it's going to be in 20 years' time. #1 is dementia, #2 is depression, #3 is ischemic heart disease, blah, blah, blah. There's this silence, and I said, so wait, I'm not allowed to smoke outside in Australia. I have to cycle to work, but if I do, I have to wear a helmet for my own good. I'm not allowed to drink more than 1 unit of Australian red wine. I'm not allowed to smoke. I'm not allowed to fuck without a condom. I'm not allowed to do any of these things, all so that I can live long enough to be demented. Depression, #2, that's a given. That's a given, But also that I can live long enough to be demented. So I do think that we need to turn the discussion about public health not just to about length of life, but, as some of you have made the point, to quality of life. And that needs to be part of this discussion. And it goes back to individual goals, as you said. It goes back to, finding what matters to you in your life and how you can promote the healthiest way of maintaining that, while not being too much of a burden on the rest of the taxpayers.
Thank you. Henry, give us your final thoughts.
Yeah, very quick. I really was struck by what you said just at the end. And it kind of does come back. I haven't really talked at all about nudge, but it does come back to nudge. It's all about people having a clear understanding of what their goals and objectives and values are, and then being aware that there is no such thing as a neutral choice that we have to make in our lives. And actually, if I can understand and set, and one of the challenges, of course, is that people devalue longer-term goals over nearer goals. But if I can understand and set my goals and values, and then be aware that there are many, many people out there who are trying to shape my choice every which way I move, then I think that will go a long way to sort of personalising some of these things. Because I completely agree with you. People kind of know what they feel, they know what they value, and they kind of know where they want to go. And then I think my final thought was, I would watch out in the next 7 months. So in the next 7 months, we have, in my world, the Chief Medical Officer doing a review, putting out a review of sensible drinking guidelines. And I guarantee one thing will happen, is as we get closer and closer and closer to that deadline, more and more and more evidence will come out, which will be less and less and less uniformly based on science, to try and influence that. And it will come from all sides of the debate. Of course, the other thing happening in the next 7 months is that we have political parties putting manifestos together. And what we find as we get closer and closer and closer to manifesto writing time is more and more evidence comes out from more and more people, which is less and less strong and less grounded. As I mentioned just now, an Ipsos Mori poll from 2003 being used today to try and influence policy. We have to be really healthily skeptical both as members of the public and those people involved in the debates. And of course, the politicians need to understand where this is coming from and why. So I think as we get closer to the kind of crux point of decision making, the evidence tends to get more and more spurious.
So perhaps, Michael, you could do a graph of quality of evidence versus proximity to an election. So Mike, Mike, swift and comprehensive.
A quick word in defence of the Chief Medical Officer, Professor Dame Sally Davis, who is not an epidemiologist, but she is actually a proper scientist. She's a haematologist by trade, and she was wheeled out in support of this Darzi Boris Johnson show the other day in Public Health. And it's quite interesting if you read the big report that they produced. Hemoglobinopathies, sickle cell disease, thalassemia are actually a significant public health issue in London. Is there anything about it? You made the point about things that are important public health that are neglected. There's not a word about it in this document. Of course, as we know, sickle cell disease and thalassemia particularly affect people from ethnic minorities and are very badly served. Many of my patients in Hackney have had very poor quality of services for these conditions. But it doesn't fit this agenda of moralising public health, so it's not an issue in the report. And the issue of again, I mean, in the issues that you quoted that she's pontificating about, way beyond her scientific expertise. And I think that's a general feature of this. Scientists are speaking way out of their range of expertise and are used as authorities in public health in a very illegitimate way. I wanted to come back in a very small point in conclusion to a point that Elizabeth made about the delay in the introduction of the campaign against smoking when it was known about the links between cigarette smoking and lung cancer in the 50s and 60s. Because Elizabeth made this point that this could be attributed to the lobbying influence of big tobacco. I think there's a much more important factor here, notwithstanding the British medical profession. There were adverts for cigarettes in the British Medical Journal in the 50s and 60s. But there was a reluctance on the part of government and the medical profession to intervene in matters of personal behaviour. And there's a very interesting statement by Lord Russell Brain, who was the head of the Royal College of Physicians, as late as about 1962, I can't remember the exact date, but he makes the point, I do not think it is the legitimate, I'm paraphrasing now, the legitimate sphere of the medical profession to be advising people about what they should do in their personal lives. Well, that sounds like a message from a distant planet, doesn't it? But there was a sense in those days that the role of government was not to intervene in people's lives, and that the individual, the civic independent citizen, was an independent, autonomous person whose liberties should be trespassed upon with the greatest degree of reluctance. And that whole sense is that cultural shift that's really gone. Because now we have that even the active consumer is highly irrational. Certainly the citizen is a very degraded concept, and the whole concept of nudged is based on the idea of the vulnerable, irrational individual whose power of decision-making needs to be taken out of them by somebody who can exercise their choice architecture in such a way that it guides them in a particular direction. That's the significant shift, really. It seems to be much more important than any lobbying. Very final point from the Darzi report. This is Darzi's response to a criticism. There's an exchange in The Guardian yesterday about this. Critics will say this is the nanny state. You've got me annoyed now, his message. To them, I say this. We face a public health emergency. If London is to be a strong and vibrant city, and Britain is to be a strong and vibrant country, we must act, and act with pace and purpose. Well, that's dangerous talk, you know. I mean, we've heard that before, haven't we? National moral revival, elevating the strong and vibrant, purging the weak and lazy. You know, let's not go there.
Please thank the panel for a great session.